So again, thank you very much. Now this will be completely different because there is almost no data driven. I'm going to, thank you much. I'm going to illustrate how we run the stroke service at our place and what we learned in the meantime. Again, my disclosures. Again, just to remind you, endovascular treatment is highly effective. Number need to treat of 2 to 3. So very effective tool available nowadays. Should be available everywhere. It's cost effective. So whenever discussions comes to whether a country or a city should implement, this is highly cost effective. That's why it's a driving, something that is driven by politics very often as well. But there's a but, as you know, it's time dependent. So the outcome of patients after 120 minutes, after 180 minutes, and 240 minutes. So every 60 minutes, you lose a lot of patients. Very effective treatment, but you lose patients. You actually don't see anything that I'm presenting, do you? Very kind of you not to say anything. I quickly start again. Yes. So I just want to say that stroke is very cost effective. Is very effective. Number need to treat 2 to 3 from these randomized controlled trials. It's cost effective. That has been shown, as I said, and that is a very important issue if it comes to financing it. So it is cost effective. You save money by treating strokes because you're preventing disability. But again, you're losing patients. So every 60 minutes, this is the amount. The green ones are the good ones. The red ones are the disabled ones. And having the very same treatment 60 minutes later, the very same treatment 120 minutes later, leaves more disabled people back. So it's very important. It's time dependent. You have to recatalyze fast. And this means you have to have very good logistics. In other words, this is where with the stroke workflow. Now, the question is, why I'm standing here. Switzerland is this tiny dot there. Have you seen this? This is Switzerland. So why should I say something clever about the world? Well, we established this service very early, and nothing is carved in stone again. So feel free to take what might fit to your area and to leave behind what is not interesting. I'm going to do it the way, and I think this is the way we look at it in Bern, which is the capital of Switzerland, as an onion. So you start in your local stroke center. What can you organize locally in your hospital between your own doors with your physicians? Then how do you organize your local network? How do you try to have a national coverage at one point? And then how this might rule out to the world. Again, this is how we do it. Some ideas might be good, some might be bad, but it might be interesting for you to understand. If it comes to stroke treatment, I think also in your own hospital, there is something I would like to always quote. It's Oscar Wilde. Discontent is the first step in the progress of man or nation. Discontent means you're not happy. If you treat stroke and you find something you work from the hospital, it's very often there's reason not to be happy. So there is reason to improve or room for improvement at many points. These are the number of endovascular cases we did over the years. So we started in 1992, obviously it wasn't me. Then in 2010, we had around 110. Now we have around 380 endovascular cases a year. So lots of cases a year. You would expect that within the hospital, that many cases, everything is perfect. Surprisingly, it's not. So this is one from my cases. Actually, a couple of years ago, I got a phone call at 2 o'clock in the morning. I was on call. 59-year-old patient in ages of 15, and he's symptomatic since 6 o'clock in the evening. Switzerland is not very big. Bern is a small country. Bern is a small city. Where did the patient stay all the time? We have an MR. This MR has been done at 1:50 in the morning, so 40 minutes before I was contacted. What happened in the meantime? So I get up, I get dressed, I take a quick coffee, I get to the angio, which takes me 20 minutes, and I expect to find a patient intubated on the angio table, and I find an empty angio. So that is a problem, isn't it? So we have lots of delays everywhere, and you search the patient, you find around the MR, 20 minutes, 30 minutes later, you finally start the treatment. And the interesting thing is, and this is commonly in every country. Whenever you try to find out what happened, nobody's responsible. So you'll never find out who was responsible for the delay. Why is that the case? So we have a pre-hospital phase and we have an intra-hospital phase. So the door to recausation time is the one that we want to reduce as much as possible. But this is not one time window. Patient comes to the emergency, is evaluated there, then is brought to imaging. Then you go to imaging, then someone has to read the images. Someone is going to inform the anesthetist or the neurologist, starting with the IV. Then IV is done, going for intubation. Finally, the patient goes to the angio. Then you do the recausation, and then he finally goes to the stroke unit. Not only that these are incremental steps, there are a couple of different physicians involved. So you have the ER physicians, you have neurologists, neuroradiologists, anesthetists. So this makes it more complicated. Now, at our site, we have 380 strokes in one center. And these are the number of physicians theoretically being involved. As all the time, anesthetists are the largest group. You can expect, although you do this all day, every day, we have more than one stroke a day, that 10% of them have no clue of what they're doing because they just arrived at the hospital. They're new. In anesthetists everywhere, there are 10%, and they are somewhere hidden in there, and they don't know how the process is. So a patient can be very lucky. The patient comes in, hits into the perfect experienced physicians. Great. 30 minutes later, and the angio recanalized. But that's some sort of a gambling, isn't it? So the patient comes in, and then you run into a diamond. At one point, you run into a plum, and this plum will delay the process by half an hour or 1 hour. So this is a problem, isn't it? And it's not the fault of the single person. It's a problem of continuous education. You have to educate everyone all the time because you have new staff. The staff is changing over time. 10% is not a lot. Now imagine you have 10 centers treating the 38 patients each. So we end up in the same, but 10 centers, you can assume that many of them haven't seen a case for a long time. So if you run into this one, obviously you can imagine what will happen. The process is much, much slower because nobody really knows what to do at which time. This looks funny, but in fact it's true. So if you look at the data of large trials like STAR trial compared to other trials, if you run a trial in a dedicated stroke sites, patients are treated quicker, much quicker. So the education of the team makes a tremendous impact on the time that you will need from door to recausation. And also the overall outcome. There are a couple of publications, just to quote some of them. Wherever you look, the higher the number, the better the education, the better the outcome is. So this is a very good argument also to centralize. Instead of having 10 sites doing something, you have one site doing a lot, because then everyone is pretty much aware of what it's doing. So continuous education is a very important issue within your hospital. And what has been proven to be very effective as well is pre-notification. So if a patient is sent from outside, you know in advance. So at our place, we know in advance that a patient comes in, the pre-notification, and the time goes down. Now, my problem is still the same. I don't know where the time was lost, because it might be during the imaging, it might be during intubation. You don't know. And one way of tracking this down is you use an app. So if a patient comes into our hospital, we start an app. It's a free app. We designed it, but if you want to have it, you can download it. It's for free. And there it's like a chess clock. Whenever a patient is handed over from one to the other, so from emergency physicians to neurologists, from neurologists to neuroradiologists, from neuroradiologists to anesthetists, you're pressing a button. And then you can track down all these time windows, and you can base it on retrospectively say, where is my delay? And you get all these data sheets automatically, and you can see where the delay is. There might be good reason for this, or you have a systemic problem in the hospital. This also allows you to evaluate your process or change processes. So, for example, you could say, I'm going to randomize patients against IV lytics to direct mechanical thrombectomy, as we did in Solitaire, in SwiftDirect. Or a very recent way of doing is you're shifting imaging to the emergency. So patient goes from the emergency basically directly to mechanical thrombectomy. And if you do so, then you can track down what the effects are, because you get all your increments all the time, and this app is available. Something that has been very helpful for us is that we define standard operational procedures, because I don't want to discuss with anesthetists at 2 o'clock in the morning when the patient should be intubated and how. So this is once described for us, but everyone who's involved with stroke patients, and then it's fixed. And from there on, we don't want to see anything else than that. Now, if you summarize this, so what are the critical success factors at your site if you optimize a site? Fast internal workflows, definitely the pre-notification of the team, dedicated stroke sites, rather centralize to few sites and have many patients instead of having many sites and few patients. Track down the workflow, that's what I showed with the app. And it's very crucial to have continuous education, because there will be new colleagues from time to time, and this new colleague is the only one on call and doesn't know what to do. And then, yes, if you want to have high recanization rates, you should have clear SOPs, and also the intervention procedure itself should be defined, so not everyone does what he, she likes. And then you can apply possible measures of quality. So door to groin time is something you would like to measure. The faster you are, the better you are. And then the recanization rates, that's some rates. This is on site level. Now, you have your site. You have optimized your workflow. You have done lots of investments. So you have MRs, CTs, 1, 2, 3, angios. Now you would like to have, you have anesthetists around, everyone is there. Now you have to have your patients coming in. And this is outside of you. So now we're talking about the pre-hospital phase. Not only that you have to make sure that patients come to your hospital, also you're responsible to some extent how fast they are. It's part of your network, of our network. This is our network. So this is Switzerland. It's not bigger than that. This is Bern. So this is the capital. And we are responsible. So we are the comprehensive stroke center. We do endovascular treatment. But we have a couple of centers surrounding us, and they do intravenous thrombolysis, stroke units. And they all refer to us. So all of them are linked to us. And this is defined by law, actually. This particular stroke unit will take the patient, do the imaging, will probably apply IV, and then the patient is sent to us, not to somewhere else. And there are certain criteria. I come to this at the end again, but I think it's very, very helpful to have clear criteria of what a stroke unit and what a stroke center is, and what kind of capacities they have to have. And within your network, I think there are two crucial things that have to be discussed, because you would like to have fast workflow and the best information from your network. So if you're working in Kanto or in Da Nang, then you would like to know or define what is done in your referring hospital. Imaging is a crucial part. So we say only who can give IV should do imaging. We don't want to have imaging and the patient stays for 2 hours there, nothing happens. If CT is available, then CT plus CTA, ideally plus CT perfusion, coming back to Kung's argument, seeing small infarcts. MR is not everywhere available. It's available at our house at 24/7, especially in wake-up stroke, or in basilar artery occlusion if the patient is unconscious. Otherwise, CT, CTP, CTA, CTP is absolutely helpful or enough. And obviously, ideally, you would like to have access to the imaging while the patient is still outside. So if there is a chance to have the images sent by teleradiology, by PACS system, this is helpful. So imaging and teleradiology, one issue that is very helpful to define in your region. The second one is transportation. Obviously, most of the transportation will be land-bound, but what you see here is we have land-bound, so ambulances which are in red. But for some sites, we define please send patient by helicopter. Why? Because we have our beautiful mountain range again. The mountain range is a typical area for skiing, mountaineering. We get so many helicopters flying every day from the mountain range back to the hospital because people break their legs or hit their head. Because of this natural obstacle, it would take by far too long to go by ambulance. To go by helicopter, one of these blue lines is 20 minutes. To go by car is 2.5 hours because you're somewhere in the mountain range. And this is really crucial. So my argument whenever I talk about is tailor this to your environment, what is possible. Not everyone has lots of helicopters around, but also to your needs. I gave this presentation more than once, but until I came to Canto, to Vietnam Canto Kung's place in 28, and since then this slide has been updated, because when I went there, I saw that this is a brilliantly organized hospital, having a CT and MR at the emergency entrance, but I also saw that they have ambulances, not surprisingly. But if you look at the map of the area, you probably tailor the transport to your needs. So you have a speedboat, and in fact they have a speedboat to get the patients, which is a very good. This is exactly tailor to your needs. What the needs are is what you do, and I think it probably absolutely makes sense that that Canto has a speedboat to pick up the patient, because there's so much water around. That's the way to go. One important issue is, and this goes back to sort of collaboration. The collaboration has to be on eye level. We are expecting the sites to send their patient. At the same time, we are only going to keep the patients that need to have treatment within our comprehensive stroke site. Once the patient is recanalized, we send the patient back. It's just a question of being fair. We are not going to drain everything, but we're going to play fair and send the patient back as soon as the patient can be sent back. I think this, at least in Switzerland, this is very, very helpful. You shouldn't mess with your sending hospitals. So if we look at this, so how do you get your patient fast in your network? This involves your catchment area. I think especially if you build up a network, it's absolutely reasonable or necessary to go around and visit the radiologist, the neurologist, the intensive care, the emergency room, and discuss with them the necessity to decide whether the patient should come or not. What we do on a regular basis is an annual meeting with our whole network. So they come once a year, we have a dinner, and we discuss what could happen, what shouldn't happen. And this is also where we talk about the required imaging and the transportation. Ideally, if you want to influence your network, you would like to have an awareness campaign of stroke. That's very complicated. It's very expensive. Probably the best way is to get it taught in schools, because teaching in school is comparably cheap compared to some advertisement in the media, and it stays forever. Something that you have learned within your first 5-6 years in school, you probably keep it forever. For us, this has been very, very helpful. So stroke is detected outside because children know what stroke is. Now, again, summarize on the regional network: fast decision-making, common agreement on imaging, teletransportation. Transportation, very good example from Kung. And you have to have a referral pattern and also send patients back. And from, at least in Switzerland, things are, if I come from university and tell someone else in another hospital what to do, they don't look at me. You have to do this on eye level. And if you would like to have measures, the possible measure of quality would then be the percentage of patients receiving adequate treatment in your catchment area. So you don't lose patients or you don't miss patients. And then the onset to groin time. So how long does it take to transport, and so on. Now, stroke networks, this is the density of population in the world. So you see there are areas which are loosely populated, like Canada, Russia, Australia, where you have areas there's no one basically living. And then you have areas which are densely populated, and especially Asia, some countries are densely populated. So there is great room for setting up good stroke networks. And if you do so right now, this is the perfect timing to do this right, because there are ways of doing it wrong. And one way is probably the US. If you look at the US, if you go to Chicago, you probably have 25 or 50 stroke sites in Chicago. If you go outside, things become more complicated. So if you look at the map, there are areas which are dense, not covered at all. If you go to beautiful Glasgow, Montana, it takes you 3 hours to get to a stroke site. Whether in Chicago or Los Angeles, you drop from one into the other. Which leads us of the problem how to do this. And I think we had the opportunity in Switzerland that we had politicians top down to decide we would like to have a national coverage because of cost effectiveness. Switzerland is very much focusing on cost effectiveness. And then the bottom up, so the physicians said, how are we going to solve this? So we said, Bern and Ticino, I was responsible to run the Italian-speaking part of Italy for some time as well. They have their catchment area, dedicated catchment area. And then we rolled out the map and said, these are the comprehensive stroke sites, and these are the catchment areas. There is an overlap, but in the end, you can say there is not a single place in Switzerland in which we don't know exactly from the beginning of the stroke happens where the patient goes. This comes with very dedicated criteria. I think that's very helpful, and also with a certain guarantee. So if you open up a stroke site at a certain place, according to the rules, no one else is allowed to open up because we want to have the patient centralized. I think that is a very good recommendation for countries which do not have a full coverage yet. Again, national coverage, centralized stroke patients is absolutely key. In the end, one day, everyone wants to have a full national coverage, and this decision might be done top-down by politicians, probably fostered or catalyzed by you, and then the accreditation criteria that can be developed by physicians or should be developed by physicians. And in the end, there are some possible quality measures as well, because you will see, if you have a full coverage, the mortality of stroke in the population will completely, or will in total reduce, and it reduces health expenses. And that is a very important point if it comes to the financing of stroke sites, stroke devices, and so on. And with that, thank you very much.
Thank you very much for excellent presentation. Any question from audience, our colleagues? Before waiting for them, I have one question for you. Is there any mobile stroke units in Switzerland right now?
No, mobile stroke unit means an ambulance with a CT inside. US, a couple of them, some European countries as well. I don't see the point, honestly. I don't see the point of a stroke unit. If we would try to cover our catchment area, we probably need 5 or 6 of them, and this is not cost effective. So you can do this if you have lots of money or want to do great advertisement, but from my point of view, it's not a way of covering large areas.
And the second question, when the new stroke patient coming, you would use MRI for screening, or you still use a CT scan for screening?
Within our hospital, we mainly use MR. We have, just for neuroradiology, we have 6 MRs and 2 CTs available. So MR is available 24/7. I think there's lots of information in MR. I think there's a certain shift towards MR in many countries now. So there are hard indications for MR, unconscious patients, suspicious patients, small infarct volumes. So we are happy to use MR as much as possible.